Hello, peoples. Let me turn my virtual background on because it's hard to see me when you have the actual background. Okay. And let me take a quick roll and then we can get rocking and rolling here on our last day. There's Dante. Yay. So glad you came today, Dante.
Me too.
Okay, quick roll. Dante Quinones. Oh, you came to every one. I can't complain. Who am I to complain? Hallie Smith. Yay, Hallie. Bailey Lyons. Gordo. Oops. Six. Barrier. Robinson. Always here when he's not in a duck stand. Alonzo. Tiana Smith, so predictable. She always comes. I guess I shouldn't complain. Salazar. Birdie. Rocky Raccoon. Simmons. Putney. Montano. So who am I missing? Evans, Cujo. Don't see him again. Okay. Gamelin has blown us off. Not to feel insulted. Okay, I guess that's about it. Oops. So I'm going to hand this over to Dr. Quinones, and he's going to take over from here. And okay, your co-host, Dante, you can go ahead and share. You're ready. Oh, Gamelin shows. Yay. Thank you, Matt. Need help, Dante? You doing okay? You're muted. Can't hear you.
Sorry. Can you see my screen?
No, we can't see it.
No. Okay.
There should be a green share screen thing at the bottom. Sorry. There we go.
There.
Now we're seeing it. Okay, go ahead.
Do I escape? How do I'm new with this. There we go. So today I'll be presenting on the use of gold nanoparticles in targeted gene therapy and melanoma. So melanoma is a type of skin cancer that starts to develop when melanocytes grow out of control. It is found in the deepest epidermal layer, which is in the stratum basal. Melanocytes produce pigment known as melanin, responsible for skin color. While melanoma is the least common, it is the most dangerous compared to basal and squamous cell cancers. This is because it has the ability to spread all over the body and the rest of your organs. Melanin is responsible for dark pigments in the skin, and it also doesn't affect people that are darkly pigmented as much. So symptoms of melanoma consist of new pigmentations, new growths, and new changes of existing growths, like benign tumors, such as moles, skin tags, warts, and lipomes. Sorry. And since melanoma can develop all over our body, it's important to check all areas. First, you want to check the areas that are exposed to direct sunlight and a lot of sunlight, which consists face, arms, back, and legs. Secondly, you want to check the soles of your feet and the palms of your hands because it can develop in dark areas too. What you want to search for, of course, is the benign tumors and skin growths, because they can grow at an abnormal size and consist of like different colors. So when you're examining your body for melanoma, you want to use the ABCDE rule, which consists of asymmetry. It looks different from the other side, and you want to look for the border if it has an irregular shape or just looks irregular. And then you want to look for a color if it varies in color, such as like brown, tan, and sometimes even like a blue pigmentation. And you also want to focus on the diameter, like the size of it. Also, you want to focus on if it's evolving constantly, like if it's constantly changing. And causes of melanoma can range from ultraviolet radiation, genetic mutations, age association, and other environments. It's also important to know that tanning beds could give you melanoma. So the diagnosis and treatment of melanoma is physical examination, which is the use of the ABCD rule by a physician, examining the skin thoroughly for signs of melanoma and questioning of family history. And another one is biopsy, which is they take a removal of the sample, as you can see here. They take a large portion of the skin, the surrounding skin, to make sure they get all of it. They want to determine the thickness. It's referring to the size, because the larger the melanoma tumor is, it's more difficult to remove surgically from the body. The thinner it is, it's way better to remove, and usually they remove it right away when it's thinner on the surface. Treatment consists of surgery, chemotherapy, radiation therapy, and immunotherapy with targeted gene therapy also. They want to make sure it doesn't metastasize, because that means it's spreading to other areas of your body, especially to your lymph nodes, because this could be a direction that is spreading throughout your entire body, and they try to remove those as fast as possible by using a dye to see if it's spread through your body and your lymph nodes. Also, they'd want to check mitosis, which refers to the amount of cancer cells dividing in that tumor. So I searched up gold nanoparticles, which is the leading application for cancer treatment and drug delivery. They vary in size, 1 to 100 nanometers. They have great biocompatibility and immunogenic capabilities, which means that your immune system doesn't really attack them. Gold nanoparticles they're using these because they have a diversity of applications, from sensoring, imaging, and drug delivery. And also they can help with diagnostics to see if you do have cancer. Their size and surface are great because they allow for surface functionality. Like you could change its charge. Also, its biocompatibility has to do with its gold nanoparticle size. So if it's larger, it usually doesn't do well in the body, but if it's smaller, it does. Shapes such as rods do exist as gold nanoparticles, but they're not frequently used because they don't help with the immune response and have more cytotoxicity when used. I focus mainly on this research article that used CRISPR-Cas9 so attached with gold nanoparticles. So CRISPR-Cas9 is a clustered, regularly interspaced short palindromic repeats with associated protein. 9 is derived from a genome editing mechanism from bacteria. It's used as a manipulation tool that can cause gene expression, suppression, and deletion within cell lines and living tissue. The mechanism derives from bacteria able to remove DNA involving viruses. First, it detects and requires the invading virus DNA to create a CRISPR arrays, and this assists to produce RNA segments to target the virus, such as like single-stranded guided RNAs from like a sequence, and the bacteria attaches the enzyme to the DNA, and it is able to cut out the virus or inhibit the virus. Here you can see that this is the main research article I focus on. They use gold nanoparticles and the TAT box attached. The TAT is a HIV transcriptase, activator protein. Its function is to bond to the gold nanoparticle and find viral repeats and activate cellular transcription. And after that, they attach the Cas9 protein with a single guided PLK1 plasmid. And the PL1K plasmid is used for sequence sequence that attaches to the specific target DNA. And Cas9 is the enzyme that removes it. Here they're just adding lipids for the increased nucleus target, because they want to target the nucleus in order to cut the DNA sequence. So more about polo-like kinase 1. Its gene is expressed during mitosis and is found in numerous cancers. It's a regulatory gene in mitosis that can be found overexpressed in multiple tumors. Due to tumor therapy, inhibition of polo-like kinase 1 has shown promising results in other researches. It's also linked to the cell cycle M phase, and this research wanted to focus more on gold nanoparticle drug delivery more than inhibiting polo-like kinase 1, because there is multiple research showing that polo-like kinase 1 inhibition or deletion causes tumor downregulation. And here you could check it. You see that it checks multiple phases throughout the cell cycle. In this first image, it has to do with the research that is showing cellular uptake in a high resolution transmission electron microscope. And this image just demonstrates the uptake of gold nanoparticles and the polo-like kinase 1 in the cellular region, and it's not separated, and it's evenly distributed. Here's a confocal electron microscope image, and it's just the use of cell dyes attached to the cell, and the cell dye attached to the enzyme, and cell dye attached to the single guided polo-like kinase. And these are just different formulas of the gold nanoparticles to see if it's actually the LGCP that is causing deletion of or inhibiting of polo-like kinase 1. And here you can see that it's not showing up in just regular gold nanoparticles or the attachment of PO1K1, that it has to have ligands attached to it to attack the nucleus. And it's just showing over time that they're showing up in the nucleus. So for the first image here, you can see that it's actually breaking up DNA by how many, it's showing cleavage of the DNA by comparing it to other negative control and regular gold nanoparticles. These are not cleaving DNA, but these base pairs showing up demonstrates that it is. And to also make sure that that it is inhibiting POK1, it's having a Western blot that demonstrates the inhibition and the percentage of POK1 that's present. And you can see that it's about like 80% effective because it's inhibiting it. And you barely even see it compared to the others. And in C, this is just a flowchart of it being positively intake and causing apoptosis. You can see that the negative control and the rest of the gold nanoparticles need to have the full complex in order to cause apoptosis, and it's just showing that in percentages. And here in D, you can see that it's comparing other sequences that may be targeted by LGCP, but they showed, they showed that it's not affecting similar sequences that affect PKO1. And all of them are negative because they don't have multiple base pairs present. Sorry about that. Here's just showing the tumor volume and sizes of the effect of LGCP. You can see that compared to the negative, tumor growth is substantial, and that they infected the tumor after it grew to like 50 millimeters, and they watched it over a course of 16 days. And with the negative control compared to, of course, the other gold nanoparticles, they had no increase compared to LGCP, that this was the most effective one. And it just shows in B, just like beating the dead horse, that is showing tumor downregulation and suppression, and that is decreasing in size over time. And the same thing goes for here, that polokinase 1 is being inhibited in the GLCP, and it's not being present at all. Well, it's being present, but at a downregulated rate. And my conclusion is that the use of gold nanoparticles for target gene therapy was effective, and gold nanoparticles can assist with diagnosis through imaging that we saw from microscope imaging and just tracing in general. And nanocarriers are becoming more successful as drug deliverers. And that's my presentation.
Okay, good. Let's throw it out to the crowd for questions. We've got two already. Matt Gamellan, are one's chances of developing melanoma more reliant on the amount of melanin in a person's skin or by the amount of time unprotected in UV rays?
It has to do with the amount of time of unprotected skin, but it has been found that melanoma has developed more in people that are fair skin, like of white complexion. So people of darker complexion rarely get melanoma, but they do have more melanocytes.
That's kind of the point of the melanoma, right? To protect you from intense sunlight?
Yeah.
Yeah, those of us who came from very far north, or our ancestors came from very far north, needed less melanin because we need to make vitamin D with our skin. But people from closer to the equator needed melanin to protect them from the UV rays.
Mhm.
Okay, how does the dye work in checking if it has spread or not?
So the dye works by attaching a fluorescent protein to the polokinase 1 and the gold nanoparticle before adding all the other attachments. So they're checking if it's actually attached and going into the cell and having uptake. But in this in this specific in this specific imaging, they use the cell dye to see if it's actually targeting the nucleus. So they're just attaching fluorescent proteins to it.
Okay, Faith Haley, is there any reoccurrence or increased risk of getting melanoma once you've already had it?
There is, but in this research, they specifically focused on rat models. So I don't know if like using gold nanoparticles, this targeted gene therapy would decrease if you would get susceptibility to melanoma again. But there's always the chance of cancer regrowing and coming back.
Okay. Okay. Any other questions, comments, discussion? All right. Well, I'm going to wrest control back from Dr. Quinones. We're going to see who's up next. Just a second, just a second, just a second. Ruth is up. Ruth Burhay. Okay, first question, Ruth. How do you pronounce your last name?
Burhay.
Burhay. See, I was doing it right.
Mm-hmm.
Everyone says I'm a fool, but I'm proving them wrong. Okay, Ruth, you are co-host. You can go ahead, bring your face up and bring your PowerPoint up, and we're ready to rock and roll.
Can you see my screen?
Yes, yes, I can.
Okay, so I will be presenting on Alzheimer's disease and its treatments. Okay, so let's go over the umbrella term dementia. So this term is the loss of memory, language skills, problem solving, and other thinking abilities due to brain damage. So dementia is an umbrella term, so it can be divided into 5 major parts. The first part is Alzheimer's disease, Lewy body dementia, vascular dementia, frontotemporal dementia, and Huntington's disease. In some cases, patients may have more than one cause, so it could be known as mixed dementia. So here again, we're going to be talking about the Alzheimer's disease. The Alzheimer's disease was discovered by Dr. Alois Alzheimer in 1906. The Alzheimer's disease was noticed in a brain tissue of a woman with an unusual mental illness. And after the woman died, the brain was examined, and an abnormal clamp of what is now known the amyloid plaque and a tangle fiber of neurofibrillary tangles were found. So the Alzheimer's disease is the most common type of dementia. It is a neurodegenerative disease and is fatal over time. So if you see the picture on the right, it is Rosa Parks, and she was an American civil rights activist, and she battled and passed away from Alzheimer's disease. So on average, people diagnosed with Alzheimer's disease live from 3 to 14 years. So who is commonly affected? The disease affects patients aging from 65 and above, but in some cases, patients patients who are younger may be diagnosed with Alzheimer's disease, and approximately 5.5 million people are affected in the U.S. Most statistics have shown that women are more likely to develop AD, and AD is not necessarily related with family history. However, if one has a family member with the disease, he or she is is at a slightly higher risk of developing AD. There may also be heritability of genes. It is not fully understood, but there are some genes that are involved in AD disease. The apolipoprotein E4 or APOE4 increases the risk of Alzheimer's. So in addition, the cognitive declines in Alzheimer's disease may also be due to health conditions like heart disease or stroke. So the causes of AD. An abnormal deposition of beta amyloid plaque is one cause. So how does this happen? Let's first understand the non-amyloidogenic pathway. So let me turn on. So over here, if you can see, there's a protein embedded in the neuronal membrane. This is the APP or the amyloid precursor protein. So it is, again, embedded in the membrane and is important for growth and repairing of neurons. And this protein, like other proteins, needs to be broken down eventually. So the alpha secretase and the gamma secretase breaks down this APP into smaller fragments so that they are like later on decomposed or broken away. And then the next pathway is the amyloidogenic pathway. And in this pathway, instead of the alpha secretase enzyme, there is a beta secretase enzyme and a gamma secretase enzyme that breaks down the APP. So when it is broken down, it's broken down into a fragment that is larger than the previous ones. So this fragment is known as the amyloid beta monomer. And since the fragment is bigger, it would be harder to dispose it when compared to these fragments. So the amyloid beta monomer is like the cell uses other steps like phagocytosis, receptor-mediated internalization, and enzymes that help to break down the beta amyloid monomer. But in Alzheimer's patients, there are increased production of beta amyloid. So the production of this is going to be increased, but but then there's going to be a decrease in the breakdown too. So there would be more accumulation of the beta amyloid and the neurons. So this can lead to neurotoxicity and degeneration. The other cause is the accumulation of tau protein or formation of neurofibrillary tangles. So the tau protein is normally stabilizes a microtubule in the cytoskeleton of a neuron. So this red things right here are the tau proteins, and so in Alzheimer's patients, the tau proteins get overloaded with chemicals that cause them to break away. So the blue dots right here on the tau proteins are the chemicals, and when these are overloaded, they break away and accumulate on other places of the neurons that again cause neurotoxicity and degeneration. Lastly, it is also thought that the decline of neurotransmitters such as acetylcholine and glutamate can lead to AD. it is all like these neurotransmitters are important in memory and learning. So there is going to be a deficit in AD patients. So area of the brain affected, the accumulation of both the neurofibrillary tangle and the beta amyloid plaque can damage the whole of the brain over time. But initially, the hippocampus and the anteriorenal cortex are affected, and this and it continues to affect the cerebral cortex as well. Symptoms of the disease. Cognitive symptoms such as attention, loss of attention, loss of perception, memory, language skills are the symptoms. Behavioral impairments can be, the patient can be more impulsive. So these treatments, these symptoms start mild and they progress through time. So the symptoms become stronger and stronger. So these are the 3 stages of the Alzheimer's disease. Diagnosis. So in diagnosing AD, there is no single treatment. A clinical diagnosis takes place. So this diagnosis is where physicians identify symptoms based on interviewing families about like the symptoms of the patients. And there are also tests of memories, language, and attention skills. Brain imaging testings. Physicians may use PET scans, CT scans, MRI scans to see if Alzheimer's is present. But the only way to be 100% sure if a person has AD is a post-mortem autopsy. So here you can see an MRI scan of a normal brain and one with AD. You can see that there is a loss in neurons with an AD patient when comparing it to a normal brain. So unfortunately, there is no cure to Alzheimer's disease. Building a care system is very important. A neurologist can work with other healthcare professionals to provide the best treatment for patients. However, there are drug treatments that AD patients could take. There is a cholinesterase inhibitors and the NMDA receptor blockers drugs. So the cholinesterase inhibitors act on acetylcholinesterase to reduce the depletion of acetylcholine. There are 3 types of cholinesterase inhibitors: the depenazole, rivastigmine, and the galantamine. So the other drug that is the other drug, which is the NMDA receptor blocker, is metonine. The drug blocks the NMDA receptors again, so the excess glutamate, excess glutamate does not bind to the receptors. So when there is an excess glutamate binding, the NMDA receptors are overstimulated. So this can lead to the NMDA receptors releasing excess CA2+, which can damage cells. And when we go to the non-drug treatments, it is, in addition to drug treatments, it is believed that non-drug treatments reduce certain symptoms as well. These treatments can be cognitive treatments where patients are given puzzles and other activities to help them remember things in the past or retain certain memories. So several research are being done in order to provide a better understanding of the disease. Also to find drugs that reduce the levels of amyloid beta proteins and drugs that target the accumulation of the tau proteins. And though there are genes that might be mutated in the Alzheimer's disease, there needs to be further understanding of those too. So possible understanding of a mutated disease is also being researched on. Thank you. Questions?
Okay, let's open it up to the floor. What do we got? Any questions about Alzheimer's? Do you know if there's any molecular-based things being researched now? Like we just heard Dante talking about gold particles getting in to kill things. I think earlier we heard about some CRISPR-Cas9 things for HIV. Do you know if there's anything like that ongoing for Alzheimer's?
I am not sure exactly, but I have seen some research on attacking, like research about finding mutated genes, because there is no enough information about the disease yet. So I think, yeah.
Okay. That's a bonus point for me. Anyone else have a question? Comment? Okay, well, we're going to let Ruth off the hook. You are done. You're no longer a co-host. And I believe our good friend Raquel Frederick is up next. I am right. I'm always right. Okay, Raquel.
Hello.
Bring yourself up there. There she is, Raquel Frederick. Or I'm trying to make you a person here.
Okay.
You're not a person yet. I mean host, co-host. Just looking for you on my list of people.
Okay. Let me see.
Why don't I see you here? Let's see this. Okay. Okay, you're co-host, so you can go ahead and start when you feel like it.
Okay.
Bring your thing up.
Not letting me share. Give me 1 second. Okay. Why it's not letting me share? Okay, let me try now. Okay.
I can see it.
You can see it? Okay.
Last.
Yeah, it is. Give me 1 second. I don't know why it's not going. Okay. Here we go. Here we go. Okay. It's loading. Can you see now? Okay. So,
Yes, I can see. I can see it. Sorry, I had to unmute myself there for a second.
no, you're fine. So I did my current research on brexanolone for treating postpartum depression. Okay, so postpartum depression is a depression that occurs when a woman gives birth to her child. It can also occur when a woman goes through miscarriage. Also, it can happen anytime during the first year of the baby's, when the baby was born. This is just a picture explaining what postpartum depression is. So the cause for postpartum depression is not, they don't really know what causes it, but as what they found out is that it can cause from physical and emotional issues, may play a big role in it. For physical change, it happens within the hormones of a woman's body that can cause postpartum depression. And also it can happen emotional issues, like if she's overwhelmed or stressed about something in her life, it can cause her to have postpartum depression after she has given birth to her child. And this is just a picture saying what causes it, what I just explained. Some symptoms people might go through, well, women will go through if they have postpartum depression, is that they will cry a lot, they would have mood swings, they would start to move away from their families, want to always be alone by themselves. They will have no appetite to eat or do like take down nothing. They would lose interest in doing like the stuff they used to, the activities they do before they have the kid. They would like lose interest and not want to do it anymore. And then they would like not want to bond with their newborn or like have a bond with the family altogether. Some signs that if somebody's going through postpartum depression is that they might feel alone. They might feel like nobody's there for them, or they might feel overwhelmed, like a symptom. And they might not have connection to the baby or towards anybody. And they might constantly think they're guilty for something. They always might try to pick a fight with something to like so they can leave them alone. And also a big one is that they would try to harm themselves or the baby just because they're so depressed. So there was 3 types of postpartum depression, but I just saw most information about postpartum depression and baby blues. Baby blues can last from the first few days that the mother has gave birth, and it might continue for a few weeks after delivery. And it's because their hormones are changing, like their body is changing, so their hormones are going to go up and down like a roller coaster, so they really can't control it. Also for postpartum depression, it will last longer than baby blues. Baby blues just is a short-term thing, but postpartum depression could be a long-term effect on a woman. And for that to be like, for them to get over it, they will have to either go to a doctor to get therapy or like take medication to get over the postpartum depression. So postpartum depression usually starts like 3 weeks, a month after they give birth, or it can start even earlier. And then it can stop when the mom goes for care or goes to seek help to help get over it, which if they go and do that, it will last for maybe it will end in like 8 to 12 weeks after they have been constantly going to therapy, constantly getting help and everything. Some risk factors that for postpartum depression is that it could be a family issue, like somebody in the family might have postpartum depression, and that new mom is most likely to get postpartum depression because they have it in their family. Or they could have had postpartum depression before in a previous pregnancy that's making it come back again because their body is used to having it, so it was going to come back again. Or they could just have a bipolar disorder, which can cause more disorders on having postpartum depression. So some women that affected, 50 to 75% women were likely to experience baby blues for the first time when they first give birth, but then 15% of them will like move on to having a severe and long-lasting depression, which is called postpartum depression after delivery. In this picture right here, it says 1 in 7 new moms are most likely to experience postpartum depression, and 19% of those moms are most likely to harm themselves. And then 50% of the moms will not seek help. They will believe that they can find help on their own, or hopefully they're just wishing that it would just go away by themselves. Some complications is that if it's untreated, it can interfere with the bonding of the baby or having family problems. For the mom, if it's left untreated for the mom, it can last longer than it's supposed to, and then it could turn into a chronic depressive disorder. And for fathers, they don't really talk about this, but new fathers can also get postpartum depression. And if they do get postpartum depression and it's left untreated, they could like emotionally strain everybody around them and put more pressure on somebody, especially the other mom, the mom that's going through postpartum depression also. And it's a risk for the if the mom is going through it, it's a risk for the father to go through postpartum depression. And some treatments that women could do to get over postpartum depression is therapy, which they will go talk to somebody about how they feel, what they're going through, and see if they can find some treatments to get over the postpartum depression. If they don't feel like they're getting comfort at home, they could go find out a therapist that are more likely to have a one-on-one and have more connection with them and tell them like how to get over it and help them proceed on to going back to their normal life. And then also they could take a medication. I'm sorry. They can also take medication, which is going to help for their mood swings and help them be more calmer and going throughout their day without having to think about something else or think about harming their kid or harming themselves. And then for baby blues, they would just tell you to get some rest as much as you can. Ask for help from your friends or family, and then connect with new moms. Like go to a mommy group or a group that just had babies also, and they can help you to tell you like what they did to get over their baby blues and how to go about it and see if what they did will work for you. But you know, some things don't always work for everybody. Some treatments don't always work for everybody. To avoid postpartum depression, they will tell you to ask help for home. Like you also, like the mom also has a dad. Well, the baby also has a dad. So the mom could be like, can you just like watch the baby while I go do like a self-care, take a nap, like write down some things that you're going through, and take a nice shower. Just focus on yourself and not have to worry about what's on the outside. Just worry about you at that moment. Just to relax, talk to people about your feelings. And also, yeah, get help from home and just write down everything that you're going through. So this is the drug that I did my research on, brexanolone. So this is just a video to tell you about what it is. It's a new research that just came out 2019 that they're trying to see if it can help treat people that have postpartum depression and see how it works for them. So I'm gonna play the video. So just to mention, can everybody hear the video?
Yeah, we can hear. Can you mute your phone? We keep hearing when you get a ding.
I know if I mute it, then you won't be able to hear the.
You're on your phone. Okay, no problem.
The video.
Treatment for postpartum depression approved by the FDA. What's really remarkable is this is the first time the US FDA has noted postpartum depression as an indication for the treatment of a new medication. And the new medication, which was approved in 2019, is brexanolone, which is a neurosteroid, allopregnanolone, which is used in an IV form to treat postpartum depression. So it needs to be delivered in an IV format in a hospital setting. And so there are some barriers to its treatment because women need to be in the hospital to receive it. So it's thought to work by modulating GABA receptors. And also being a neurosteroid has potentially an impact on women who may have a hormonal component to postpartum depression. What's really novel about it is that it has a rapid onset of effect, and the studies show. So just to mention, need to be in the hospital. Being a neurosteroid has potentially an impact on women who may have a hormonal component to postpartum depression. What's really novel about it is that it has a rapid onset of effect, and the studies show.
So this video is just basically telling you like what how they're using brexanolone to help with postpartum depression. And so so I did my research on brexanolone to see how it works. So it's a very new study, and what they did is they took four patients each. So they gave the brexanolone to 4 patients and a placebo to another 4 patients to see how it works. And then they did 2 trials. In the first trial, they did 60 hours and 90 hours of giving the patient the brexanolone, and then the other 4 the placebo. And then in trial 2, they just gave 90 hours of dosage to evaluate the placebo to see if the results they got was actually valid. So after they did the 2 trials, they came to the conclusion that brexanolone has been working for people with postpartum depression, and it has been having a good outcome and throughout the whole 2 trials. So that was my presentation, and this is my references.
Okay, I'm going to throw it out to the floor. Hang on, I've got some questions. I need to back up to get to the first one. Wow, a lot of questions. Okay, first one from Evans Cujo. Was there any information supporting the fact that fathers also experience postpartum depression once mothers start experiencing it?
Yes, they did a lot of research that, because usually they don't really talk about, well, people don't believe in postpartum depression. That's the first thing. People don't really believe that women could go through this type of depression after having a baby. So when they, it just came out like last year about postpartum depression. So fathers do get postpartum depression because they can also have, the mom can also be putting stress on the father. So the father will get overwhelmed from the mom being stressed also.
Okay, good answer. As more and more men are raising children, could men go through the signs and symptoms of postpartum depression? So again, not because the mom is, but him on his own because he's stuck home alone watching children.
Well, I didn't see nothing about that, but I believe they possibly can because we are human, and even though they might feel some weight on them because it's like, I gotta take care of this kid on my own. So possibly, yeah, I haven't seen any research, like only information talking about like if it's a single mom, a single dad, and him raising his own child. But I believe that they will go through some symptoms and go through stress themselves. Everybody goes through stress sometime in their life.
Okay. What about extremely introverted moms who don't like talking to others about their problems? How are they likely to get over this depression?
I feel like they could buy a journal, or like they should know like at least someone close to them that they feel comfortable talking to about what they're going through. They should at least have, even though they're introvert, they should even trust their husband or the baby's father to talk about, I'm going through this situation, postpartum depression, like I need somebody to talk to. So they should have at least one person that they could talk about their feelings or how they're feeling. So yeah.
Okay, got a lot of questions here. This has really sparked a lot of interest. So Nick Putney asks, are there any differences in symptoms between postpartum depression and depression unrelated to giving birth?
I'm not too sure about that. Like the symptoms, he's asking, can you read the question one more time?
Sure. Basically, he's asking, is there a difference between postpartum depression and regular depression?
No, people will go through like basically the same symptoms in having regular depression and postpartum depression, because it's still a depression that a female goes through, just that they give birth. And like if you have regular depression, they basically go through the same thing.
Okay, are there any drugs moms can take to maintain hormone levels to prevent postpartum depression?
I didn't look at the medication they can take for postpartum depression, but since this new study came out, they're trying to give it before a mom goes through postpartum depression to see if it's gonna have the numbers gonna decrease from when it was increasing before the drug came out.
Okay, one last question from Matt Gamellan. Can parents who adopt a young child experience this?
If it's a newborn and I believe so. Like if somebody has adopted a child, they will feel overwhelmed because now they got to worry about another human being coming in their life. So now they got to readjust their whole life, fit like everything else in their schedule, and have to work around their new member of the family.
Okay, good. All right, so I'm going to wrest control back from Rocky.
Okay.
Withdrawing your co-host credentials. And our last talk is Smith. the other Smith, Haley Smith. Haley, can you bring yourself up? There she is. Hello, Haley Smith. You're muted.
Hello.
Okay, now you are co-host, so you should have a share screen thing at the bottom.
Yes.
Good. We can see it fine.
Okay, so the topic of my research was complex regional pain syndrome and the treatments for it. Complex regional pain syndrome, it's a neurologic chronic pain condition. Usually it affects a limb, sometimes multiple, sometimes it can affect the whole body. And symptoms are things like burning pain, swelling, discoloration, loss of mobility, and among a billion other things. It progresses in stages, so acute, subacute, and chronic. And over these stages progress over like the length of time that you've had it, and it progresses in the way that it starts affecting other parts of your body. So like if you've had it for a very long time, it starts to affect the chemistry of your brain. So sympathetic nerve blocks are one of the first treatment options that they usually give. And this is just, they insert a needle into the ganglion in your spine, and they administer an anesthetic to kind of act on the nerve by itself. It's less invasive. Usually you would get multiple of these injections over a series of weeks, and they have less long-acting side effects, but they also go away over time. When performed less than 12 weeks after onset of symptoms, they have shown to be very effective and very nice, but after about 25 weeks, they didn't have a lot of effect. And 84% of people have side effects with them, but they are short-lasting. They do go away over time. Another treatment is ketamine. It acts by blocking the NMDA receptors in the brain, which would prevent pain-related signals from being transmitted. It's been shown to work in both the acute and chronic stages of CRPS, which shows that this might be a treatment option over a long period of time because other treatments don't last that long, or they don't work after that long of a period of time. Usually they only work within the first year, and most people don't get diagnosed until years after they have symptoms. There was one study that recorded fMRI data of a patient's brain before and after ketamine infusions with various stimuli, and it was shown that there's a lot less brain activity during these stimulations after the ketamine infusions. Spinal cord stimulation, it's another common method of, sorry if you can hear the banging, it's another common method of treatment, and it's a little more invasive. They go in through your spine, and they insert electrodes, and you can have a trial period, which is just a week, where these electrodes stick outside your body, and you can determine whether you like it or not. Success is determined as 50% or more pain relief, but there is a very high complication rate In one study, 51 patients underwent 122 reinterventions, and over 40% of the patients had the stimulator removed by the end of 10 years. And even then, like, these stimulators only last 2 to 5 years in general before they have to be replaced, because the battery either dies, or if you get one that the battery can be recharged, it ends up breaking. There was one study that was done with high frequency spinal cord stimulation, and it was shown that in some patients that had failed normal spinal cord stimulation, this high frequency did work better for them, but it was still less improvement overall, and they also had a great decrease in symptoms, a decrease in effectiveness over time. Dorsal root ganglion stimulation, it's an alternative to normal spinal cord stimulation in that the electrodes are put into the dorsal root ganglion, which it gives a more specific stimulation. And because normal spinal cord stimulation, you kind of get like a tingly feeling, and it's over a broad area rather than just where you have pain. Whereas the dorsal root ganglion stimulation, the doctor can put it exactly where your pain is and have it be a lot more specific. And it also lasts it lasts longer than the normal spinal cord stimulation, in that the stimulation doesn't fade and your nerves don't get used to it over time. It is still an option after failed spinal cord stimulation, as they've if you've had normal spinal cord stimulation and it hasn't worked for you, you can still get dorsal root ganglion stimulation and see if that would work. One study did concurrent spinal cord stimulation and dorsal root ganglion stimulation, and it was proven to work better together than either stimulator alone. Big downside of that is that you would have two battery operated things to worry about implanted in your back, and you can't go through MRIs or airport security very well after that. Epidural infusions are a much less common form of treatment than any of the other ones already mentioned. And what they do here is they insert a catheter into the epidural space and they tunnel it under your skin for a couple inches just to lower the risk of infection, and they leave it in for about 6 to 12 weeks whilst you're undergoing treatment, like other treatments and like physical therapy and stuff like that, so that you can get your mobility back before they take it out and see if you're better. And within 1 year, these infusions work very well, and 17 out of 19 patients saw complete recovery, but after 1 year, 17 out of 19 patients, the opposite way around, received no benefit. In children, CRPS is a very rare disease, and it's not really studied very much, but epidural infusions have been tested in a very small number of children, and they have been shown to be successful even within days, rather than the months that they would be implanted in adults. And that's my references.
Okay, we're going to throw to the crowd. A quick question. These electric stimulators, are the stimulator itself implanted internally?
Yes. The electrode is in your spine, and then the stimulator is implanted like right above your butt.
Okay, so like subcutaneously, but not like inside your body cavity?
Yes.
Okay. And do they have any idea what causes this pain, or is...
They think it's just a kind of like mess up in your sympathetic nervous system where rather than, so it happens after and like a inciting injury, and instead of your nerves thinking that it's going away and like knowing that it's healing and getting better, they kind of just think that it's constantly under like this stressor and being attacked, so they don't stop sending those pain signals.
Okay, that makes sense. It's kind of the hyperactive nerve that doesn't know when to stop. Kind of like when your professor keeps talking, he doesn't know it's someone else's turn to talk. Okay, Celine Ramos wants to know, what age group is most affected by this syndrome? By the way, should be affected and should be affected. Okay, Celine.
The highest age group to be affected by this is people over 40. Getting it at a younger age is a lot less common, but not unknown, and the youngest person to get it was 2 years old.
And didn't you say if they catch it early, it's easier to treat than if it goes longer?
Yes, so there have been studies that have shown within, like if you catch it within a couple days of even having it, if you do like small treatments and just like get them on painkillers and stuff like quick enough, it can go away relatively immediately. But if you've had it for over a year, usually you have it for the rest of your life.
It must be hard to make that diagnosis though, you know, it's pretty uncommon. You've got pain and your GP says, take some Tylenol, it should go away, you know? So,
yeah.
Okay. Evans Cujo wants to know, what parts of the world has the highest risk of the syndrome?
It's kind of like just, it's not, I don't think it's parts of the world that have like higher risks because it is just nerves. They think that there might be a genetic link, but it's very low, if anything. For example, there's, I think, 15 million people on Long Island and only 1,000 people have it.
Okay.
So there's not a lot of studies done on it in general, and I don't think that's, I haven't seen anything about that.
Okay. Faith Haley asks, would these treatments relieve all types of pain or just ones caused by this disease?
These treatments, I mean, the ones that were specifically acting like the spinal cord stimulator, it would act on any sort of pain that you had in that area, just because it is kind of numbing the nerve. And things like the sympathetic nerve blockades, those would only work on stuff for like the sympathetic nervous system, like this disease goes through.
Okay. And she would also like to know, would your body still feel pain if injured while undergoing these treatments?
With things like the sympathetic nerve block, yes, but otherwise so like the stimulators, it kind of, instead of pain, it kind of just produces a like television static, like if your leg goes numb feeling, just in general, overall, continuously.
I have a question too. With the stimulation in the dorsal root ganglia, do you also lose like your proprioception, like not just the pain neurons, but also the neurons that tell you where your leg is, that kind of stuff?
No, you still have that. It's just kind of a weird thing to get used to. It's like walking with your leg half asleep.
Yeah, okay. Okay, well, I guess that's about it for today and for the semester, frankly. So I even checked, I'm hoping everyone's already got their resume and cover letter in. If not, please get it in by tomorrow. I'll try and get your feedback back on that by next week. The 4 people who talked today, I'm going to send you an email and I'll talk to you for 30 seconds after this thing is over. Other than that, anybody have any questions or comments? Anything you want to know from me? Nope. Okay, then we're going to call it a class, a day, a week, and a semester. See you later, guys. Love ya.